I am Kellie Moore. I'm a second-year pediatric resident at the University of New Mexico, and today I'll be talking about emergency contraception for adolescents and young adults. My first thought, actually, when I was thinking about a subject, was to pick long-acting birth control, which I'm a big fan of, but I noticed on the website that Jen Robinson did a fantastic presentation on that in January, so I decided to use emergency contraception instead. So this is kind of the next step after that. Obviously, long-acting birth control and other contraceptive methods are the way to go to prevent pregnancy in the adolescent population, but this is a good way to do it if you absolutely have to. If someone comes into your office and says, you know, I had unprotected sex yesterday, what do I do now? So, there we go. So the big things that I want to talk about, what I think people should know about emergency contraception is its history and the role that it plays now in teenage pregnancy prevention, as well as the differences between the different types, their effectiveness. There is a relatively new one that came out called Ella, which came out at the end of 2010, really came into use in 2011, which not everyone knows about. And then what's the availability and specific concerns of emergency contraception to teenagers. So first of all, emergency contraception, again, is a backup plan, but it's important because teenagers and adults who are using condoms, every day 27,000 of those break or slip. So this is when emergency contraception really comes into being important. The other thing is that 49% of pregnancies in the US are unintended. That doesn't necessarily mean they're unwanted, but it does mean that people that have unintended pregnancies do not have adequate prenatal care. Well, they have care during their pregnancy, but not before. So they don't have pre-pregnancy risk identification. Their pre-existing conditions aren't managed or identified, like diabetes, things like that. They're not using prenatal vitamins. Now it's recommended, of course, to use folic acid before you get pregnant to protect against spinal cord defects. And then, of course, they may have had alcohol or other drugs previous to or during the pregnancy that they didn't know about. So it's not an ideal situation to get pregnant. And of course, also emergency contraception can be very useful after a sexual assault. So specifically concerning emergency contraception in adolescents, a lot of people think that if adolescents have access to emergency contraception, they decide that they don't have to use protection during sex, and that, you know, this is kind of not just a backup plan, this is something they just plan to do. But it actually, a lot of evidence shows that having access doesn't increase the rate of unintended pregnancies or STIs in the teenage population. In fact, after using emergency contraception, they're more likely to start using a regular method of birth control after this first time that they use EC. Another myth is that they can't understand the product labeling. Again, studies show that they do understand the labeling just as well as adults. They know how to use it and when to take it with a little bit of guidance from their pediatrician. So other barriers specific to adolescents for emergency contraception, a lot of it is a lack of information. Not a lot of people talk about it. Again, I think people think talking about it will make teens think that they can use this as a first-line defense to pregnancy, which they don't usually tend to do. So I think educators, school-based health providers, other adolescent providers should be a resource, should kind of bring this up in as, you know, as a normal part of the well child exam for teenagers. There was a study that found that only 50% of pharmacies keep it in stock. So this is in regard to the Plan B, the levonorgestrel method, which I'll go over in just a second. Obama recently, I think in 2013, signed an act that said that Plan B is available to anyone over the counter in the pharmacy of all ages. So even though that's true, still only about half of pharmacies were found to actually have it in stock. And of those 50%, actually 66% kept it in a locked case, which is a barrier to adolescents who really value confidentiality. So they had to go to the, you know, go to the store clerk and have them open the case for them, which they tend not to want to do. Another thing is the cost. So the generic levonorgestrel is the most, is the cheapest form, but still costs about $30 a pill if you don't have insurance. And again, this is over the counter, so some insurances won't cover it anyway. And again, with teenagers specifically, transportation to the pharmacy can really kind of raise some confidentiality concerns. If they can't get to a pharmacy, they have to ask someone to take them, and just in general, confidentiality with teenagers. So just a quick history of how emergency contraception came into being. The first thing was in the mid-1960s, people started using high-dose estrogen. So this is when contraception, the pill, actually came out to begin with. So they had the pill, they just took a bunch of them and hoped for the best that it would also prevent pregnancy after sexual intercourse. In the 70s, the use pay regimen came into being, which is similar to what was happening in the 60s. Now with combined OCPs, people would take more than the usual amount as a form of emergency contraception. This is still done today, and I'll talk about it a little bit, but it's one of the least effective methods of emergency contraception. In '84, we got the Paragard, the copper IUD, which is actually the only IUD approved for emergency contraception. Did not really come into wide use until, honestly, the last probably 5 or 10 years. And then in '97, we got the FDA announcing that combined OCPs can be used as emergency birth control, which had been done since the 70s, but now is FDA approved. And then the next year, they approved an actual product, Previn, which was the first product marketed as emergency contraception. That was discontinued in 2004 because it was basically the use pay regimen, and we have better ways of doing it now. In '99, we got a progesterone only, the Plan B, and now available without a prescription as of 2013. And lastly, the newest thing is Ella, which is ulipristal acetate, and that's now available in the US as of the end of 2010. It had been available in Europe a couple years before that. So I really like this graphic, and this is one of the reasons I actually wanted to do emergency contraception. I was introduced to this by Jen Robinson at one of the health clinics. Bedsider.org does a great job of explaining contraception to teenagers. They have a really cool website, and this is one of their graphics that you can actually get tear sheets and posters made of to give out to teenagers. So these are the big three ways of doing emergency contraception. The Paragard is the most effective. It works within up to 5 days after unprotected sex. The Ella is the next most effective, and then Plan B is also the third most effective, and then the use pay regimen, which we'll talk about, is kind of fourth if there's no other option. So the copper IUD is the only non-hormonal form of emergency contraception. Everything else is, a form of hormonal birth control pill. It's the most effective. So the pregnancy rate, or what you could consider the failure rate, is 0.9, so 0.9% of women that used it as emergency contraception did become pregnant. It can be placed within 5 days of unprotected intercourse, and actually, if you know the woman, or the woman knows her schedule really well and knows exactly when she's ovulating and she's regular, you can actually place it up to 8 days after unprotected intercourse, as long as you know that it's before ovulation. We don't exactly know how copper IUDs work, but they seem to have copper ions cause an inhibitory effect on the sperm. They adversely affect the endometrial receptivity, so they make the environment poor for implantation, and so that's how we think they work. And then the hormonal IUDs, Mirena and Skyla, which are hormone-eluting IUDs, are not approved for emergency contraception. However, there are some studies that are using Mirena as emergency contraception in addition to oral birth control pills at the same time, and those have been really effective. So that way, the woman is left with an IUD at the end to go forward, but also is getting some emergency contraception as well. That hasn't been approved yet, but it's in the works. So a lot of people are worried about IUDs. It's kind of a big thing that's hard to counsel teenagers on. There are 4 risk categories that are used for contraception as far as risks and benefits. The only absolute contraindications to a copper IUD, which is considered the category 4, the unacceptable risk, is a current pregnancy. So if you know the woman is pregnant at the time, if there's any sort of pelvic inflammatory disease, purulent cervicitis, gonorrhea, or chlamydia. Obviously, if was just an immediate post-septic abortion, it's a bad idea. If the woman has copper allergy, or she has a uterine anomaly. There's actually no other absolute contraindications to the IUD. So that brings up the question, if a woman just had unprotected sex, how do we know she doesn't have an STI from that unprotected sex? And there's a couple ways that people have handled that situation. On the Princeton website, they say that they will go ahead and put in an IUD, do the STI testing at the same time, and then if the STI testing comes back positive, they'll just treat the STIs. They won't remove the IUD, because overall the benefit of having the IUD outweighs the risk for them. Other people will say, you know, this IUD has effectiveness up to 5 days after unprotected sex, so depending on when it happened, we'll test for STDs, and then if it's negative, we can still put the IUD in as long as 5 days haven't passed. So it just kind of depends on the practitioner, how they feel about the STD risk with a copper IUD insertion after unprotected sex. There are category 2 risks that pertain to our population. So a lot of people talk about how IUDs should not be used in women who haven't had prior pregnancies. That's actually not true. It is category 2, so considered advantages generally outweigh the risks of putting an IUD in a woman who hasn't had a baby. And then also in the teenage population, again, it's just a category 2 risk. So generally, IUDs are placed in women under 20 who have not been previously pregnant. And of course, with all IUDs, there's always a small risk of infection, exposure, and perforation, but obviously we take measures to prevent against these things. The next one, which is the second most effective, is the ELA, ulocrystal acetate. Again, this was approved by the FDA in 2010 in December. So this has a failure or a pregnancy rate of 0.9 of 2.1, still pretty good. Again, you can use it up to 5 days after unprotected intercourse. And this one is different than the Plan B or the levonorgestrel because it is just as effective on day 5 as it is on day 1. There's some concern that with Plan B, it is most effective sooner. This one doesn't seem to have any difference. This is available only with a prescription, which is kind of that double-edged sword. So most insurances will pay for it because it's prescription only, which is good because the cash price is about $40 to $50 for the one pill that you take. With a prescription, a lot of people have you know, a $5 to $10 to $20 copay. It is not a generic, so it is a brand name drug. And then there were concerns about people, you know, taking it too often, using it as regular birth control. There were studies done that show there were no adverse effects if you use this. Oh, that got cut off. No effects after using every 7 days for 8 weeks. So they did a study and had women use it once a week for 8 weeks. There were no adverse effects. A lot of them did start ovulating again, though, so that is not a good form of emergency contraception to use this more often than you should. And then there were some concerns in Europe that this may be less effective in overweight and obese women. That's a little controversial. There haven't been good repeat studies done about that, but it may be possible that it's less effective in women with a BMI greater than 30 and possibly ineffective with a BMI greater than 35. So in our New Mexico population, that's definitely something to kind of keep in the back of your head. This is the one everybody's pretty familiar with. This is the Plan B. It's now generic, so it comes in a lot of different formulations. There's My Way, there's Next Choice. It's all high dose levonorgestrel, 1.5 milligrams. So this has a failure rate of about 0.6 to 3.1, not too bad. And this can only be used up to 3 days after unprotected intercourse. And again, it's thought that it works better sooner. Again, works by delaying ovulation and is especially effective before the LH surge. So there are generics available. This is over the counter, which means some insurances won't pay for it, although sometimes if you write a prescription for Medicaid, they will cover it. And this, again, may be less effective, according to some studies in Europe, if women have a BMI over 25. So this is actually a little bit lower than for the ELA, or ineffective as a BMI over 30. So technically the copper IUD is the only one that hasn't at all been shown to be to have any problem with overweight or obese women. There was a study done, I think, in Europe where the Plan B dose is 1.5 milligrams, and they were giving women with a BMI over 30 twice the dose, so a 3 milligram tablet, and it did seem to increase the effectiveness. So there may be some possibility that just doubling the dose in obese women may make it just as effective. So the use pay method came out, this was actually the first kind of form of emergency contraception, and this is basically great for women who are on the birth control pill, maybe skipped a day or two and then had sex. That way they can just take more pills than they would otherwise to kind of make up for having that lapse. There's lots of different ways to do it. It depends on the type of birth control they have at home. But basically you want to get them close to about 100 micrograms of the estrogen and then about a half milligram of the progesterone, depending on whatever kind they have in the pill. So again, this works great if a girl has the pills at home, they can just be told to take a few more over the phone. Again, though, it is the least effective way of doing it and has the most side effects. Basically, in general, all emergency contraception has the same side effects: so nausea, abdominal pain, breast tenderness, headache, dizziness, fatigue. It's all the same with all the different methods. This is a great chart on the Princeton website, and this shows specifically which birth controls, how to take them with the use pay method. So for example, if a girl calls and she's been on, you've been prescribing her Lovora kind of towards the bottom there, just say, okay, take 4 white pills now and then take 4 white pills in 12 hours. So you can, you have what color pills they should take, so they're not taking the placebo pills, and then how much of them they should take to make that about 100 micrograms of estrogen. And so this is a big thing, giving advanced prescriptions. So when girls are in your office, you can give them a prescription for the birth control, the emergency contraception. That really increases access. The WHO, the AAP, Society for Adolescent Health and Medicine, and International Federation of Gynecology and Obstetrics all recommend advanced prescriptions. Even for over-the-counter, having a prescription, again, may defray the out-of-pocket costs, just because Medicaid especially will pay for an over-the-counter prescription or an over-the-counter medication if there's a prescription. And then, again, there's no evidence that adolescents are more likely to have intercourse after receiving an advanced prescription. So that's about it. These are my references. The Princeton website is a great place to go, and bedsetter.org is one of my new favorite websites. So thank you very much.